Hi everyone, this is Jason Profetto, where I'm the chair of clinical skills at McMaster's undergraduate medical program. If you are watching this is an orientation video for the clinical skills section in MF4 or our medical foundation 4. I'm going to go through a few things. It's not going to be anything too extensive, but it will be quite inclusive, and I'm going to show you the manual and a few tricks. I am going to start with our PowerPoint, and then I'm going to make my way over to the actual manual itself. So, clinical skills is something that we're going to be teaching every single medical foundation. So, just a quick review for those who are not familiar with the undergraduate medical program at McMaster. There is the pre-clerkship and the clerkship. The pre-clerkship itself is divided into 5 medical foundations or units. Medical foundations 1, 2, 3, 4, and 5. So this is number 4. And the current curriculum, and I say that because it's going to be changing next year, but the current curriculum is that Medical Foundation 4 is a focus on host defense and neoplasia or infectious disease medicine and oncology. Clinical skills will have some focus on those specific things, but it's also going to be a bit more of a review as well, right? So each medical foundation has several mandatory pieces to it. There are tutorials, professional competencies, and clinical skills. This says what is clinical skills, not what are clinical skills. Clinical skills as in a piece of the overall curriculum. So tutorials happen twice per week, and it's usually Monday, Thursday, or Tuesday and Friday. And they are 3 hours, and they're generally in the afternoon or evening. Professional competency, whereas tutorials focus a little bit more on the academic content, for example, what is lung cancer and going into proto-oncogenes and the actual physiology and anatomy and pathophys. Professional competencies is a 3-hour session every Tuesday morning between 9 and 12, and it's the second mandatory part of the curriculum. It focuses on concepts around professionalism, ethics, communication. This is where there are SPs that you learn about breaking bad news. Or, for example, this coming week, we're going to be talking about domestic violence. We've talked about anti-oppressive practice in the past, abortion, and many other things that relate to medicine but have a very sort of philosophical and ethical context behind them. Clinical skills is the third mandatory piece of the pre-clerkship. And clinical skills is a focus on teaching and learning the history, physical examination, and then starting to get comfortable with what we would call diagnostic testing. But the bulk, the focus of clinical skills is really on history taking and physical examination. And I say that because it's important we ensure that that's indeed what we're teaching, and we don't get too heavy on the chalk talk or the academic tutorial didactic-based learning. So the way clinical skills will run is there will be one session per week that will last approximately 2 to 3 hours. And MF4, I believe, is 10 weeks. It's 10 weeks or thereabouts, something like that. And there's going to be a session every single week. The first session will be next week. So that's going to be the week of April 22nd. And the session itself will have specific agenda items that are available in the clinical skills guide or manual. So you'll know exactly what's expected and what topics are going to be covered each and every week. It will be 2 resident preceptors, right? So everyone is paired with another resident as a preceptor. All of our preceptors in clinical skills are residents, and you will be assigned a group of 7 to 8 students. This group is also the tutorial group. So this is the same group that meets twice a week in tutorial, but it is not the same group as the professional competency group. The PC group or the ProComp group is a group that is set in the fall and meets every week for 15 months consecutive with a break in the summer. So this is the same group that will be new as of next week, and you guys will be meeting once a week, 2 to 3 hours, and you can meet anywhere in the Hamilton area or any of the hospitals. the health science section, we have the Center for Simulation-Based Learning, which is called the CSBL, which is 1M and 1G, and that's in the hospital. All of these specifics about the locations that you can meet, where you would meet, how to book rooms is all available in a document that's going to be coming to you called the Frequently Asked Questions for Clinical Skills. And when you do meet, the goal is to be teaching and reviewing clinical skills, so the history taking and physical examination. The scheduling itself, so generally what happens with clinical skills is it usually happens in either the late afternoon or evening, and usually between Monday to Thursday, so one of those nights. There are times when we do them on Friday or on the weekend, but that's usually if there's scheduling challenges for the preceptors or the students. Now, this is a mandatory part of the curriculum, so that means that students must attend. And if a student cannot attend more than one session, so if they miss more than 10% of the sessions, which is more than one session, they have to make it up with remedial work. And if you get into that scenario, you have to let me know, and then we can help guide you in terms of what to do. If they have interest groups or extracurriculars, that is not a valid reason to miss clinical skills. They can apply to miss a session with a leave of absence form, and that's fine. But if it's more than one, more than 10%, then they have to do a remediation to make up the missed work. We are well aware that residents have clinical duties, call schedules, etc. So week to week, it may not be possible to book the session every single time at the same time. Students are aware of this. Try to be as organized and flexible as you can within reason, but in the end, it really does depend on your schedule and your availability. You do have two preceptors, so if one week only one of you guys could make it, that is totally cool. If you both wanted to go every single week, that is also cool. I think most people end up breaking it up like that, where they both attend every week, and then they split the group into two when they start to observe or teach clinical skills. I know some groups have split it up where they take 1 week on, 1 week off in terms of their availability and that sort of thing. And just make sure that you negotiate this with your group. And again, try to be flexible with the students, but they have to understand that they have to attend this and they can't start to abuse the schedule. So, we promote problem-based learning and self-directed learning. And I think here the most important thing is to really foster an environment where self-directed learning helps or guides you at least. And the reason I say that is because getting a strong sense of where the students are, their comfort level, how they want to practice the histories and physical exams, where they want to practice, and what makes sense, it's really helpful. So when I teach clinical skills, I always try to check in with the students. Where are you guys at? How are you feeling? Are you keen to go into a hospital? Are you keen to book a standardized patient? Do you want to practice amongst each other? How would you like to see this happen? What are your sort of goals? And the reason I ask is not because the students can sort of dictate everything, but within reason, it really helps to know where their comfort level is and building up to a gradual exposure to higher fidelity exposure. So at first, they may want to practice something like the peripheral vascular exam. If they want to look at legs and examine legs, they can practice amongst each other or a standardized patient before they start to go into a hospital setting or booking real patients where they might be a little bit more nervous, right? Or the opposite may be true. They feel like they really haven't had ample patient exposure and they really, really want to start practicing on more patients. So my big thing is really get a sense of where the students are at. So do a little bit of a briefing check-in at the beginning. How is everyone? Where are we at? What do people want to do? And then at the end, do a bit of a debrief and a checkout. How did it go today? What do you think worked? Is there anything that we can change? And this is all within reason. So we have to understand that we might not be able to get standardized patients every single week. We might not be able to get hospital patients every single week, right? And there are going to be times when it's going to be difficult to book patients and other times where it's very easy to book patients. So it all has to be flexible and understanding, and we do that in conjunction with the students. When we teach too, there's a clinical skills guide, and maybe the next point is the clinical skills guide and manual. So I'll go there now. The point is that this clinical skills guide is available to all the students and all the resident preceptors. This has been years and years of work, and you can see that there's about 300 pages here. It's a very, very inclusive manual. There's a bunch of preamble information, mention of the AFMC National Clinical Skills document that gives like sort of national standards on what students should be teaching. But if you actually go to the schedule, you'll see MF1, MF2, MF3, and then if you go down, you'll see MF4. So this is what we're going to be teaching, and you'll see two things here. There's specific clinical skills that are going to be taught and new for MF4. That'll be the lymph node exam, the dermatological exam, and then some specific things in pediatric growth and development. If you actually look at the MF4 weekly session guide, this is the 10 sessions. See, I was correct. There's 10 weeks here. And it'll tell you each week what is expected. So in week 1, we're going to be doing an introduction to clinical skills and an overview of the lymph node exam. And then week 2, we're going to be going to dermatology, so this is the first time that students will be exposed to the dermatological examination and an introduction to describing rashes. There's going to be an ENT theme. This is not the first time that it's being seen. It'll also be an MF1, and it's going to also be a review, so it's a bit of a spiraled curriculum. We're also going to be doing a review of the peripheral vascular exam and the heme exam. So this comes from, this is a spiraled curriculum from MF1, and whereas we did benign hematology in MF1, we're now looking at some hematological malignancies as well, like leukemia and lymphoma. We're also going to be introducing some other things related to pediatrics, so the newborn history and the adolescent history. Obviously, this is going to be a little bit more challenging to get actual patients, right? We're going to be reviewing the diabetic physical examination, and then we're also going to be doing a review of the abdominal, respiratory, and cardiology themes, right? And so these are things that come from MF2, MF1, and MF1. So these are all hyperlinked. If you go to session 1, if you click on it, it'll be it'll actually be a hyperlink and show you what MF1 session 1 is. So the agenda, discuss expectations, history, and physical. So this is sort of like a group discussion, just reviewing everything, and then we're going to go to the lymph node exam, right? And as you go down, it's very simple. You'll see the different things that are included in each session 2, session 3, and session 4, and so on. And each week has different things, right? So we're talking about a rash in in session 2, but we're also going to be reviewing a JAMA article, does this patient have a mole or melanoma? And then there's some flexible objectives and some feedback. So it's fairly straightforward. It's fairly easy to follow, right? And then if you go back to page 6, where the schedule is, and you click on these different things that are going to be taught. So the dermatological exam, we talk about how to take a history for a rash, things like the rash itself and the growth, and things that are tailored specifically to rashes in the history, right? And the relationship to medications and allergies. And then you'll see this too. We'll have different sort of diagrams and charts and just sort of describing what certain things are and how the descriptors that we want to use. One of the things, I'll mention it now too, so melanoma is a good example. In the updated version, which will be coming up next year, we're also focusing on diversity and inclusion in clinical skills. So for melanoma or rashes, there's going to be a section about people of color and Black individuals whose skin may present in a bit of a different way, and just the variances, the normal variances that you should consider and look for. So anyway, you'll see a bunch of different stuff here, and then this is why we bring things out from the JAMA Rational Clinical Exam Series, because it gives us some pretty cool information about how to apply the ABCDE checklist and different sort of likelihood ratios if they apply, or sensitivity, specificity, and how it actually relates to clinical skills. So that is all available in the guide, and you can play around with this, and the students will have this as well. And there's a lot of information here. It's a very inclusive guide. One of the criticisms has been that there's too much information in this guide, but I think it's more or less fairly user-friendly. Please stick to the guide, though. I guess that's the big point, and don't deviate too much from it. So we say that the best way to learn physical examinations and histories is to practice with actual patients. There's a few levels to this. So level 1 is students can practice amongst themselves, which I'll come back to in a second. Students can book standardized patients. Students can practice on actual real patients. And those are the three main ways that you can use patients for the purpose of clinical skills. Students practicing on themselves is okay. We do have a rule that you cannot practice physical examinations on more private areas, right? And not to get too basic or too patronizing about this, but bra and pelvic area, breast and pelvic region, even the abdominal region, anything that would be covered in a full truncal bathing suit is probably off limits. So head and neck is okay. It's an opt-in system, so if students are comfortable, they can opt in. It's not an opt-out. It's not assumed that students will be practicing on each other. Legs and feet and arms and extremities are okay if the students are comfortable. And of course, you can adjust as you need. Like we don't need to get down to bare skin every time if that's inappropriate. But examining the legs and the feet can often be comfortable for many people. You can book standardized patients. So each group per MF has 8 hours of standardized patients in total. That is information on how to book that. It's all available in the FAQ sheet. You can also, so if you're working on a ward or a clinic and you have access to real patients, that's totally cool. You can use them for teaching purposes as long as you explain the nature of what you're doing, you obtain consent, and they understand that it's for teaching purposes, right? Above all comes the safety of patients. So just make sure that you're communicating and you're role modeling in a very professional and appropriate manner. And then there's also the St. Peter's. So St. Peter's is an affiliated hospital setting with complex patients that are available for our clinical skills teaching. So you can actually book through St. Peter's real patients that have complex issues that will be vetted, screened, and consent will be obtained by either the patient or the family, whether or not they can participate in a teaching setting, And again, that is all available through the FAQ. So there's a lot of ways to get patients, and whether it's fellow students, standardized patients, St. Peter's, hospital patients, or clinic patients. Please ensure that you do use patients as much as possible and where appropriate for teaching. Evaluation is very important. So there's going to be 2 formal evaluations that'll be mid and end of unit. It's easy because it's triggered via email. So one of the resident preceptors will receive an email from MedSys, and you'll be asked to fill out an evaluation form for the mid and the final. What you put on an evaluation should never come as a surprise. That's a big thing for me. At the end of the unit, you should not be giving feedback on the final eval that the student has no idea about. It's very important that you finish these evaluations within 2 weeks of them coming available. That's an accreditation standard and can strictly affect in a negative way the accreditation of the medical school. So that's very, very important that they're done in a timely fashion. I always say giving feedback every single session, ideally to every single student, is very important. And it's much better than receiving one evaluation at the mid and one evaluation at the end point. So talking to students, giving them feedback on a regular basis makes a huge, huge difference in learning outcomes. Real-time feedback is one of the best ways to learn. At the end of June, which will be the end of this medical foundation, is the medical student's first OSCE. It is their first year OSCE, which is their first OSCE, and that's the end of June. This is partly why we put a review of the abdominal exam, cardio and rest, an introduction to some pediatric themes, etc., because an OSCE is coming up. It's very important, and we really, really try to stress this. We do not have a separate clinical skills expectations for the OSCE compared to real life. What you would do in real life is what we would promote you do in the OSCE. So, for example, if in real life, when you're doing the respiratory exam, you tend to auscultate and maybe percuss, but you really don't do egophony, then that's what we would recommend you do in an actual auscultation and explain why. So you can say, for example, doing an abdominal exam, when I am detecting splenomegaly, the physical exam is limited, and there used to be Trobe space, but now what we use is the Castell sign, and then you can percuss Castell's sign. And articulating that it's of limited use and it's not diagnostic in and of itself is accurate and fair, and that's what we would promote. You can say that you've learned techniques related to whisper pectoraliloquy and egophony and tactile fremitus, and you can perform them, but they're of limited use and generally people don't use them. That is okay. Like, that's a very fair thing to say. So what we teach in clinical skills is exactly that. That's what we hope to teach, and it's also what we do in real life, and it's also what we would do in an assessment, something like the OSCE. So I would teach, just really try to teach what clinical skills generally should look like, what is of limited use and what is not, right? Professionalism is big, so we hope that students present themselves appropriately. There is no specific dress code, right? And this is always something that you have to use your discretion. If we're going to see patients and a student is wearing shorts and flip-flops and a tank top, I would probably say that's not the most professional thing to wear. If someone is wearing, like a darker pant and a button-up shirt and they seem professional, I think that's much more appropriate. There was a time when certain things would be controversial, like tattoos exposed on the arms and hands, or the color of someone's hair or something like that. Those are not things that affect professionalism, in my opinion. And there's a fine line between what is professional and what is not, and I think it's a case-by-case basis. So I have really not had a lot of issues with this. I find most medical students completely understand and are very reasonable about what professionalism is and what it looks like. And my recommendation to students is to present yourself in a professional way that you would be comfortable if you were the patient seeing a physician, right? So that does not mean that everybody has to show up with a suit and tie. It can mean a variety of things of how we present ourselves. But professionalism also refers to how we speak and how we conduct ourselves. So, I would hope that the language we use is appropriate and inclusive. I hope it's polite and courteous when we speak to patients, especially when they are participating in a teaching setting. I want to put this here. So diversity and inclusion is something that I've done a lot of work with in the last couple of years. The updated guide, which will be released soon, is going to have is very explicit diversity and inclusivity mentions, and especially things that relate to LGBTQ, and especially the trans population and trans-sensitive health. There's going to be some stuff around Indigenous health. There's going to be a lot of stuff around people of color or different skin tones. There's going to be a chunk of sections that are going to focus on people with different body habituses or individuals who have higher BMIs. And then there's going to be the parts about examining individuals with a disability and how you would alter the physical exam. And these are important points. I mean, if someone comes into a clinic and they're in a wheelchair because they're unable to walk, so say they have Parkinson's or MS or cerebral palsy, just for examples, the expectation of them getting up to lay on a bed may actually not be safe. So if you're going to be doing an abdominal exam, you have to tailor it based on the individual in front of you. For example, another good example, like I mentioned before, is if you're going to be looking for skin cancer and doing a dermatological exam, or even detecting something like eczema, it'll be different in an individual that has a lighter complexion, say someone with an English, Irish, or British heritage, as opposed to someone that is black or Afro-Caribbean in heritage, right, or ancestry. So, or someone that comes from a South Asian or Middle Eastern country or population or community. So we have to be able to tailor these things that are appropriate, and there's going to be actually very specific teachings. And especially in the LGBTQ sensitive clinical examination realm, how we address individuals, how we ask their name, the use of gender pronouns and preferred gender pronouns, and how that comes into the clinical exam, right? So that's actually just talking about some of the future changes. And I think I'll probably end it there. So if you have questions, please feel free to email me. I hope this was helpful and it was inclusive. The only other thing is I want to show you, this is the clinical skills manual that I was showing you. Can we actually go back to the Med Portal page? So if you go back to the Med Portal page, you have to go to Undergraduate, Medical Foundations, Medical Foundation 4. And if you go to week 1 and you go down to clinical skills, you'll see that this is the actual guide. It'll show you the weeks, like the themed weeks each week. This is the AFMC National Clinical Skills document. This is a national document that describes the expected performances on the different clinical examination techniques across the country. And then the Rational Clinical Exam Series. Does this actually work if I click it? I haven't clicked this in a while. But this should bring you to the actual JAMA Rational Clinical Exam Series. And then you can go through all of these different issues, right? So these are very cool to go through, and it's not to get too deep into the statistics and epidemiological application of this information, but when it's applicable to different things that you're using in the clinical skills of MF4, it can be really helpful. So on that, I will end, and if you have any questions, let me know. Thank you so much for participating, and it's really exciting to have you guys participate in our clinical skills. Thank you.